it's been a pleasure to sit in the background and listen to the last few talks because they've really been fantastic. However, it also just points to the fact that I think we're all seeing the same patterns and in many ways fighting the same battles right now. So some of the core themes related to central cord syndrome have already been covered. So I'll gloss over those and move into more practical topics. Look, why are we talking about this? And Jens, I appreciate your assigning this topic to me because this is less controversial, I think, in a lot of ways, and so it doesn't necessarily open the door to my getting bludgeoned by Jim in the aftermath. But the fact is that in the United States of America, this is now the single most common form of spinal cord injury. And so for whether we paid attention to this or not in the past, this is front and center in 2021, moving into 2022 and beyond. And as our population continues to age, this is only going to become more and more common. So I'll just go through a couple of facts and figures and then just talk through the evaluation and treatment of this, and then where are we going next? And then I'm happy to answer any questions. Central cord syndrome was first described by Richard Snyder at the University of Michigan in 1954. And we're all well aware of this. It's a syndrome that's characterized by the upper extremities being injured more significantly than the lower extremities as far as the neurologic manifestations are concerned. In essence, by definition, central cord syndrome is not an ASIA A injury. So there is intact rectal tone and rectal sensation. These are classically an ASIA C or ASIA D, but in rare circumstances, you can get a very, very dense central cord that's an ASIA B. There is bladder dysfunction in this patient population, and it's classically a retention instead of an incontinence. Variable degrees of sensory loss, but with the classic presentation of burning hands. And then this is typically an hyperextension injury in the setting of pre-existing spondylosis. And then if we just remind ourselves of the anatomy that we learned in medical school and beyond, it is because the upper extremity fibers of these tracts, in particular the lateral corticospinal tract, the upper extremity fibers are located more medially, more centrally, and that is why you get this disconnect in the, or this disparate impact on upper extremity function compared to lower extremity function with central cord syndrome. So just very, very quickly, the most common type of spinal cord injury in modern days is an incomplete injury. The most common pattern of incomplete injury is a central cord syndrome. And when you do the math, that is why this is now the single most common presentation of spinal cord injury in the United States in today's age. The classic patient is a male over the age of 55 who presents after a fall, as Jim wonderfully talked about previously, that these are low velocity mechanisms of injuries and different from the impact of the high velocity fracture dislocations that have been the mainstay of spinal cord presentations over the last 50 years. So we'll just talk about this in the setting of a case. It's a 55-year-old male, falls down the stairs. He had a previous C5-6 ACDF, and he's on Eliquis because he had had a DVT. He's alert and oriented ×3. You're seeing him with his cervical collar in place. He has nothing in his delta and biceps. He's 2 out of 5 in a wrist extension and triceps. He's got nothing in his hands. And he's weak, but anti-gravity in the lower extremity muscle groups. And he's got this classic burning hands that he's complaining about. So, we have a few things we got to ask ourselves when we see this patient: what, how, when, and then what else are we going to do? And there is his MRI, which is the classic situation. We already had enough cervical spondylosis to warrant an ACDF, but now you can see above his ACDF is additional cervical spondylosis. And it's this hyperextension injury from falling down the stairs that induces the central cord syndrome. So my first question is, does this patient need a cervical collar? And, I'd like to open that up to the group, and I'd be very curious, Jim, what's the practice at Thomas Jefferson in Philadelphia. Some of our more esteemed senior colleagues, I'd be curious your perspective on, does this patient need a cervical collar?
Hang on, Jim.
No. Oh, sorry.
No? Okay.
I was going to say,
one of
go
our,
ahead, sorry.
let's ask the next generation, Dr. Cliff Pierre.
Good morning, everyone. Again, for me, I would recommend, even though the CT scan doesn't show any acute injury, I would recommend a collar just for stabilization until you get further studies, as you have an MRI up on your imaging, just to further show the extent of injury at the level of the cord.
Yeah, and that's a little bit more senior, my partner, Dr. Amir Abdul-Jabbar. So central cord, significant injury. Here's Amir.
Hey there. I think, we could expand this out to cervical collars in general and how much they actually do for our patients. In this setting, I don't know that it's going to do a whole lot, but I think all of us do it to make ourselves feel a little bit better.
All right, we'll pull. I'll bypass the next row. Let's go to Bijan. He's been very quiet. He's been very patient. He's gotten all the insults and slights from Drs. Harrop. David has been quiet so far.
David, from the type of question that you have proposed, the answer is no. But personally, I don't have any control, and Nathan can verify if I'm lying or not. Putting a hard collar at the shock trauma is not under my control. If it was under my control, I wouldn't use the hard collar for this patient.
Let's go to the co-chair. Dr. Daly, you've written multiple guidelines.
Yes, because it tells everybody the guy's got a spinal cord injury.
Dr. Ramey has shown that he's not afraid to say contradictory things to his senior people.
I would not put this patient in a cervical collar. There's no instability, so I just don't think it does it a whole lot.
So you heard a brief review of some experienced people in the audience. What do you make of this, Dave?
Well, I think that it's a fascinating question in this specific circumstance, because it's actually different from the question of the patient who's just being evaluated in the trauma bay who has a negative CT scan. But has no discernible spinal cord injury. This person has a spinal cord injury. And so I think that actually, if this person doesn't have a spinal cord injury, the CT scan's negative, you take off the collar. And I think that the faster everybody catches up to that just being a simple fact, the better off our patients will be and prevent and limit them from the harm of cervical collars. But I think Andrew's point, which was echoed in certain ways by others, is actually a germane point here. The person has a cervical spinal cord injury and has not yet had a definitive plan put into place. And I think the presence of a cervical collar is a reminder to everyone involved that this is a patient who still requires evaluation and management. And so I'm actually not morally opposed to the cervical collar in this situation, the way I'm genuinely morally opposed to the cervical collar being left on the patient who doesn't have a spinal cord injury and has a negative CT scan. Because I think that it does highlight the fact that this person has a spinal cord injury. The cervical collar itself is not going to do anything for the patient, but it does sort of change the management angst around the patient. So I don't think that, and then Bijan correctly pointing out the form of the question. The form of the question leads to an answer, no. Does the patient need a cervical collar? This patient does not need a cervical collar. Is it okay to have a cervical collar in place? I think it's okay to have a cervical collar in place.
So just quickly, in the audience, there are multiple chats. By the way, we're over 100 on Zoom, and we have the same number between Facebook and Instagram. So it's cool to see all of you, and welcome around the world. Special shout out to Professor Dubussé. It's an honor to have you there. Oh. And Michael Failings is just saying hello also, so we can weigh him in and box him in. I think from what I'm hearing you say, David, it's so important because the audience was very much in favor of a neck collar. Can you just clarify one more time? Suspected spinal cord injury collar, yes or no?
Suspected spinal cord injury, I leave the collar in place until there's a definitive management plan.
Great, thank you. I just want to clarify that. If Michael Failings is live, do you want to pipe in?
Yeah, I would concur with that. I just got into the latter part of the discussion. Looks like we got a person with a central cord syndrome. Yeah. I think that it's reasonable to leave the person in a cervical collar and to define the nature of the injury, and then to figure out what it is that you want to do with the patient. So I think in this case, I would kind of start off with the cervical collar. And then, the majority of patients in my practice with the central cord syndrome will undergo decompression. And then once that's done, if you're happy with the internal fixation, I don't generally use a collar.
Excellent. All right, Dave. And nice to see you again, Michael. Great lecture this morning. Thank you.
And then, the next question is, will you operate on this patient? But I think we'll in the interest of time, we'll keep moving on this because there's been so much discussion about this in the last few talks, which has just been fantastic to see. And we'll come back to this central question. It's interesting how this has evolved because, again, the first description, 1954, University of Michigan, that was a case series of 9 patients. 2 underwent decompression, one of whom deteriorated to tetraplegia, the other of whom improved to an ASIA D, and then 7 were observed or underwent posterior fixation only without a decompression. 2 of those patients died and 5 of them improved. And so the original conclusion was that you actually shouldn't operate on these patients. But if you look more carefully, the surgery that was performed was actually pretty fascinating because the decompressions were a laminectomy followed by dural opening, section of the dentate ligaments, mobilization of the spinal cord, and then an anterior osteophytectomy from a posterior approach. So I don't know anybody left on earth who would perform this particular operation. And, I applaud the vigor with which they were attacking a dangerous situation in the early 1950s in Michigan. But this is a pretty dramatic operation. And so I don't think it's surprising that there was a risk of deterioration as a result of the surgery when this was the decompressive surgery performed. So there was the original conclusion that prognosis is good without intervention. The surgery is morbid, so don't do it. And then timing of surgery wasn't addressed because their perspective was surgery wasn't supported for this condition. Then in the 1990s, things started to change. But as a prelude to that was this building understanding that maybe the prognosis isn't as fantastic as was originally presumed in the absence of intervention. And though you can see improvements in motor scores without intervention, there are still substantial impacts on quality of life with or without motor improvement. And you have to remember, it's not just about motor improvement, even though that's ultimately the metric that all of these things get judged by. But this patient population has many, many more manifestations of central cord syndrome than just the impact on motor function. And it's important to remind ourselves of that. And it's pretty fascinating that 78% of patients with the central cord syndrome have 2 or more of this list of neuropathic pain, bowel dysfunction, bladder dysfunction, or sexual dysfunction. So there is a substantial impact on quality of life. And the recovery in the absence of intervention needs to be judged beyond just the motor recovery aspect. So there's the myth that the prognosis is pretty good without intervention. There's the myth that surgery makes patients worse, so you shouldn't do it. And that's where I'm saying that as we emerged into more modern times, we started to see the building of an evidence base from the 1980s through the 1990s that showed that surgery not only was not unsafe, as in surgery was safe, but surgery was starting to show a pattern of having a beneficial effect on this patient population. And then that led into some of the things that have already been discussed in the last few talks, which have been fantastic. So here we have a 55-year-old male who's a C3 ASIA C, central cord. Are you going to take this patient to the OR now, tomorrow, later, or just at your convenience?
I'll be the roving reporter.
I'll be the roving reporter. Andrew.
As you had stated, I would try to take the patient to the OR as quickly as possible because he's an Asia C. He's a relatively young man by my standards, and I'd like to get him decompressed as quickly as possible.
Wyatt Ramey's next. The Young Guns from Texas.
Yeah, within 24 hours for me.
All right, short and sweet. Bijan, I'm going to exclude you. You're going to be the voice of wisdom. Cliff?
Within 24.
Within 24. I'm here. No take.
I agree. Sooner is better with an Asia C. If it were less severe, I would maybe change my response.
John, sorry, we had the Pittsburgh battle, so we kind of postponed your lab.
No problem. I would actually take this patient at my convenience. As long as they're improving. If they're deteriorating, that's a different story.
When's your convenience like?
I would discharge
Monday
them.
morning, Monday afternoon?
No, I discharge them, see them in clinic, and as they improve, then talk about an elective surgery.
So a patient who's 3 out of 5 strength in his lower extremities is going to get discharged from the hospital.
No, sorry. I was thinking of a patient that has mild hand dysfunction, but is still independent. Central cord typically affects the hands more, right? So if they're
I guess you walked in late because you were getting things set up. But this is a patient with an Asia C, pretty significant deficits in the upper extremities, and is only 3 out of 5 strength in the motor groups in the lower extremities.
Thanks, David. Yeah, if it's an inpatient and can't go home, then I'll do them later.
Later. Okay, Monday. Bijan, you get the last word.
I would take the patient to the operating room during daytime and probably the beginning of evening, but not at 2 o'clock in the morning. If the patient comes in at 2 o'clock in the morning, I'll take the patient to the operating room the next day, the earliest possible.
Yeah. So, Jim Harrop and I do agree on many things. And the fact is that I've just reached a point in my life where I believe that the patient with a neurologic deficit referable to spinal column trauma should go from the trauma bay to the operating room. And so that in this setting, that's what I'm doing. It's not within 24 hours. It's not, at the next window that seems to fit into other factors. We just go from the trauma bay to the operating room.
I think that's supported by evidence as well, David. And I think if this were, an 85-year-old on apixaban, that's a different matter. You've got to then, sort the patient out medically. But this is a person without medical comorbidities. This person has, forget about central cord. This person has an incomplete cervical cord injury with compressive pathology. And you describe it that way, say, oh yeah, I better take the patient to the operating room. And time is spine. I mean, and the data that we are now putting together does show a time-dependent effect also for these Asia C central cord injuries. They behave very similarly to other patients with an incomplete cervical cord injury. The patients with a milder Asia D injury, they kind of resemble a bit more like the progressive myelopathy cases. And I think you can make an argument to, maybe delay it a day or two and kind of let things cool off a bit. I wouldn't be critical of that. But I think the central take-home point here, 55-year-old person, no medical comorbidities, incomplete cervical cord injury, you take them to the operating room.
And how radical then, Michael? This sounds good in theory. Would you be a little anti-decompression or in one of those very bad-looking necks, multi-level posterior decompression infusion?
Most of the cases have underlying cervical myelopathy, as you know. A lot of them have multi-level degenerative disease. So probably one of the commoner operations I will do will be a multi-level posterior decompression fusion. You got to individualize it, obviously. If somebody's got disc issues and you can get, you can deal with it effectively with an ACDF, fine, I'll do that. But probably the most common operation, Jens, that I will do will be a posterior decompression fusion.
Jim Harrop has his hand raised, and I want to go to you next, Jim. But Michael Feelings, laminoplasty in central cord, does that have a role or is it a fusion?
I think it's a very valid option if there's no fracture. I think, you do what you feel comfortable with and what works well in your hands. And For me, I prefer the option of laminectomy and internal fixation for this particular condition, but would not be critical of someone who is very experienced with laminoplasty using that as an approach.
Jim, you've been very patient.
No, I was actually going to say, and Dave, this is a great case, but when we talk about central cord injuries, I think everyone has a case in our heads. I mean, I'm typically thinking about my average 75-year-old patient who's probably myelopathic, who tripped at home, who's on some antiplatelet agent. And I think the message for the group is, and I totally agree with you, this person, 55-year-old, no other medical issues, bad injury, take them to the OR, because again, what do you have to lose? And I think you're going to have, but I think just to clarify it for the younger people, we all have preconceived notions. And two quick comments I just want to make. One is, I think every single central cord I've ever operated on, except for a young person with acute disc herniation, because remember, central cord is a clinical diagnosis, I've done posteriorly, which I thought was interesting. And the second thing, which is kind of interesting, one of the benefits no one ever talks about, that dysesthesia they have in their hands, sometimes if you decompress them early, particularly if it's unbelievably, it gets better if you operate on them early.
And operating on early, just one more time, I'm slowing the uptake. Do we do a durotomy, then also an expansion duroplasty and add about 2 hours surgery time, or do we just leave it to the extensile post-decompression fusion?
Well, Dave does that with his 3.0 Kerrison.
All right, back to you, Dave.
All right. Well, look, I intentionally, chose the picture of someone that would lend to a more controversial discussion. Look, there's already been some fairly robust discussion about this again over this last session, and but there's just this growing and ongoing body of evidence. This is one of the things that Michael Failings helped lead with AO Spine. We're just seeing this stronger and stronger and stronger pattern emerge for the benefits of early surgery. I will tell you that one of my frustrations is that we continue to define early surgery as within 24 hours, whereas I believe that that we really need to understand the difference between immediate surgery and early surgery. We simply don't have enough data to do that. And also the timing of surgery is so often dictated by when the patient arrives at the institution. And Jim showed a nice snapshot of what that looks like in trauma registries. But in the end, where I'm hoping this conversation is gone, because the conversation has certainly moved dramatically over the last 5 years to a stronger and stronger clarity that early surgery holds benefits at large for this patient population. I'd like to see us get into two things. One is the difference between immediate surgery and early surgery. And two is a better and deeper understanding of the impact on these patient populations beyond the motor effect. Because I've had the same observation that Dr. Harrop mentioned, which is that I see an impact of early surgery on the burning hands, for example. What I don't have clarity on is what is the impact of immediate or early surgery on autonomic function. I just don't know the answer to that question yet, but I hope that we start to hone in on those things as we move forward.
One quick thing. Yeah. So Dr. Jesse Caballero wanted to have the following question answered, and that is MAPS above 85. That applies to central cords as well, right? Until you get to the OR and through the OR.
In my opinion, yes. And in the interest of time, I'm just going to finish up with one more with one more facet of this case, and that would be this exact question. And so we have a 55-year-old with a C3 Asia C. What blood pressure parameters are you going to set for this patient? And in the guidelines, the evidence that goes into the guidelines, we don't have a very clear picture about this specific question if you parse out the central cord syndrome population. But in the end, and Dr. Failings has also been a huge net contributor to this, Charles Tatter in the earlier days, giving us clarity that one of the principal secondary injury pathologies here is a lack of oxygen delivery to the injured spinal cord. And so for me, I believe that the answer to this question is a MAP greater than 85. However, what we're actually moving very rapidly towards, and we've already adopted in my institution, is spinal cord perfusion pressure management, which we are also applying to the central cord syndrome population. And in our institution, if you are Asia C or below, you end up with a lumbar drain, and we measure intrathecal pressure, and we guide our management not just purely off of MAPs, but off of spinal cord perfusion pressures. And spinal cord perfusion pressure is the mean arterial pressure minus intrathecal pressure. And so for us, we're not doing this to the Asia Ds, but we are doing it to Asia Cs and below, and across all comers, not just the central cord syndrome population.
Great. Hey, Dave, should I just follow up on that question? I think that's a great, and I actually wrote an answer to one of the questions. Here's the question I have for you and Michael or anyone thing. We made up that number 85, and I don't want to get into the details on it, but it's somewhat of a made up number. These central cord injuries that I've seen through my practice, the great majority of them ride their blood pressure above 85 because they're hypertensive to begin with. Do we need to start thinking about elderly people and pushing their means higher? Because really, then I'm going to just answer this in this different way. Putting a lumbar drain in drops your intrathecal pressure down 10 points if you think about it that way. And it just, if you double their systolic, are you doing the same thing as dropping their diastolic by 7?
Yeah, I don't know the answer to that question, but the data that has emerged, and this isn't the only data set on this, is that spinal cord perfusion pressures 65 at a minimum. When you get to that 65 millimeters of mercury as a spinal cord perfusion pressure, you see strong correlations with improvements in Asia grades or conversion in Asia grades. And so I don't know whether it's better to get there by dropping intrathecal pressure or raising mean arterial pressure, but it's the goal is to get to the same place, which is a spinal cord perfusion pressure of 65.
Great stuff, guys. So this is really important. Go ahead, Dave. Any other summary findings?
No, I think in the interest of time, I'll stop there. And if anybody has any questions, I'm happy to answer them, and we can stay on time. And I again thank you for the invitation to join. And I'm sorry I'm not there in person, but I hope to be there in person next time.
No, this is an amazing group of people. I think all of us are in awe of the collective wisdom that has come together here in the Zoom space. So, Michael, to put you on the point now, your lecture this morning was excellent. What is the optimum treatment then for a central cord syndrome patient with significant deficit? Should we kind of wait at least for 24 hours, or if we have a nice OR, nice staff available, the patient is physiologically in reasonably good shape, should we take the patient to the OR? Should we basically do a little anterior decompression, a bigger posterior surgery, MAPs above 85 or higher? Should we do a durotomy? Should we do a cord release? Just give us a very brief kind of bullet point ideal treatment in your perspective. Bijan gave a great perspective earlier, and we've had Jim, Dave, and Andrew talk about it also.
Thanks, Jens. So congratulations for putting on this symposium. And I hopefully next year, right, we can all be together in person. So you've raised a number of the key points. So let me maybe just kind of break it down. So number one is that, we're probably stuck with the term central cord injury, and it's a phenotype, but really it's an incomplete cervical cord injury. And the outcome is really very similar to other incomplete cervical cord injuries. And to a large extent, it's dictated by the baseline neurological status. So if you have a person with a severe central cord injury, and by that I would take it an Asia C, which is quite impaired, unless there are significant medical comorbidities, and there can be in this patient population, then I would consider early surgery. And I quite agree with David, early means early. And, the Staskis, the Staskis trial was initiated over 15 years ago and was published over 10 years ago. But the mean time to decompression in stasis was 14 hours. So people need to remember that. Okay. So, all right. So I would say, early surgery, that's safe. So, so I would kind of make that a point firstly. And then anterior versus posterior, well, you go where the money is. And if, somebody's got a soft disc herniation that's in the front, ACDF is the way to go. 2-level spondylosis with cord compression in the front. Anterior, if you've got someone with multi-level and a kind of a washboard looking type of spine, usually posterior is optimal. The issue of durotomy, I think, is very controversial. It's a hypothesis, and Marius Papadopoulos is trying to do a trial with regard to this in the UK, and we'll see what that pans out. I think that before I would consider the option of a durotomy, and if you're concerned about residual intradural tension, you could do an ultrasound through a posterior approach. And if you did see that there was significant cord swelling, that might be an option to consider. But I don't use durotomy currently in my practice routinely in this type of a setting. And then I think Dave Okonkwo nicely kind of covered a lot of the points, and I contributed to that to that discussion. I wanted to follow up on a point that David and Jim and others were bringing up around perfusion to the cord. I think an important principle is maintaining perfusion to the cord. That's clear. And where we now need to evolve is, clearly the number 85, it wouldn't make sense that that's the right number in every single person. Like, no two people are the same. In the absence of other parameters, it's the best we have. And I think the concept of spinal cord perfusion is a very good one. The caveat I'll make with the lumbar intrathecal monitors is the cord has to be decompressed. So if you've got a decompressed cervical cord and the subarachnoid space is patent, putting a catheter in the lumbar space will give you a reasonable estimate of what's going up and down. Don't rely on that, though, if you've got a dislocated spine and there's pressure. I'm sure you would agree with that as well, David. We know that, right? You would have a block in the
100%. But you also just recall that for us, immediate surgery represents virtually every spinal cord injury patient, and therefore decompression is part and parcel with that. And so, I feel pretty comfortable with what it is that we're measuring. However, I would love to have the spinal cord version of what we have in the brain, where I'd have a direct interparenchymal measurement at the site of injury.
And maybe the engineers, will come up with some ways for us to do that. That would be a wonderful advance. And I mentioned that in my lecture that, I thought that was, kind of going to be where we, will be going in the future. So the AO is right now looking at, with Brian Kwan and myself and others, we're looking at updating the guidelines on spinal cord perfusion management. And I think mainly to point out the knowledge gaps, and then to suggest currently, the options of measurement of intrathecal pressures. And, we'll see how strong the recommendations come out. I suspect that a lot of it will probably be at the option level still. But I do see that the field is kind of going in that direction.
So one more quick question, then we'll need to move on. So this is a historic, for me at least, an amazing opportunity to see all of you keeping this together. Wyatt Ramey in his lecture earlier raised the issue of should we actually exclude or separate central spinal cord injuries from spinal cord injury research, clinical spinal cord injury research, due to its different recovery profile. And I know you just called it a standard incomplete cervical spinal cord injury. So if I can go around the room, maybe Jim, do you want to take a first stab, then David, and then we'll ask Michael and then people in the room. Should it be a separate category, David? I can't hear you.
I believe that it needs to be a separate category, but I think that we should be structuring trials that parse out the completes from the incompletes. Now, this is such a challenging issue. Many of us, participating today have devoted tremendous effort and energy in our careers to pushing the envelope in the spinal cord injury population. And prospective interventional trials in spinal cord injury are perpetually hampered by enrollment because the disease is, in fact, an orphan disease. And so we're struggling so hard on the recruitment side that it's severely hampering our capacity to measure the effective interventions in a prospective interventional model. So I think we actually need to think differently about how we learn from the spinal cord injury population, at least in the next epoch of time, because we're struggling to do it in a prospective interventional way.
Jim Harrop, Central
Yeah,
Court.
I'll throw. I think it's a poorly worded. I think it confuses everyone because it's a clinical diagnosis, right? Hyperextension injuries with hands worse than the arms. I mean, hands worse than the legs. Nowhere else in spinal cord injury do we make that distinction. And then we are simple people, so we categorize people and we throw it in this box, which we should just get rid of and think of spinal cord injury as spinal cord injuries. And the problem is we have a ceiling effect with these patients with their hands. So I would agree with Dave that we need to scrap the thing, make it more expansile on the end with the fine motor and hand function, and get rid of a word we like to use because it's easier for us to think about a group of patients.
Good. Back to you, Michael. So Wyatt gave a great talk about just what Jim and Dave also said. Are we too limited? Are we too antiquated with our Asia scoring? We don't have sexual function there. We don't have autonomic dysreflexia in there. We don't have a myriad of other things, spasticity, for instance, in there that matter a lot to spinal cord injury patients. Is it time for an overhaul?
Yes, it is. It's not to say that we need to throw the Asia system in the wastebasket, but we need to look at other approaches. I think Dave Okonkwo raised important points. So I do agree, David. I think we need to think about the enrollment and the analysis of the clinical trials differently. So the challenge has been, how do we manage the heterogeneity? And one of the ways has been just to try to limit further, limit the enrollment. And it's gotten to the point where it's almost impossible to enroll people because it's so limited. And still we have heterogeneity. And I think there are, emerging statistical algorithms to look at prediction modeling, and we need to start thinking outside the box a little bit more in terms of, how to use the clinical data. And with machine learning, we can have very rich data sets that take all things into consideration, not just motor function, sensory function, autonomic function, all of these different things, and really start looking at it and embracing the heterogeneity, but then using these statistical approaches to then look at the patterns as they emerge. That might be, a way for us to try to detect the signal that we're likely to have with some of these medications and other approaches that we're trying to test. So, I think it's an exciting area, but I do think we need to shift. We need to shift in the way we're looking because it's incredibly, I just went through the very challenging experience with, enrollment in the RISCUS trial, which we've now concluded, and we're now in the middle of analyzing. But I can tell you, we can't continue with these efforts where, it's taking 8 to 10 years to, recruit patients into trials.
We'll need to move on. This was an amazing constellation of the minds and thoughts, and